Dr. Suma KV, Madam is a professor of anesthesiology at JJM Medical College, Davanagere. She did her MBBS from WIMS Bellary in 2001 and MD from Mysore Medical College in 2007. She has 6 publications and has been PG guide for more than 5 years. She has her interest in pediatric anesthesia and biomedical research, and she is passionate about teaching the postgraduates. We welcome you, madam.
Special moment for me to be back in my alma mater. I'd like to thank the organizing committee. Most of them are my teachers for giving me this opportunity. Myesthenia gravis is the most common autoimmune disorder that affects the neuromuscular junction. Fluctuating painless weakness and fatigability of the skeletal muscles with improvement following rest is the hallmark. These patients can present to us for surgical procedures, for diagnostic studies, or for intensive care. The disease is seen in women in 3rd decade of life associated with thymic hypoplasia, and in men in 6th decade of life mostly associated with thymomas. This can also be seen in children. The weakness in myasthenia gravis is due to a decrease in the functional acetylcholine receptors at the neuromuscular junction. This is mostly autoimmune, antibody mediated, and the antibodies commonly implicated are those against the acetylcholine receptors. There can be changes in the postsynaptic membrane as well. There could be loss of synaptic folds and widening of the synaptic clefts. All this can lead to reduced margin of safety of the neuromuscular junction. It can be either ocular or generalized. In the generalized form, involvement of the laryngeal and pharyngeal muscles can cause difficulty in chewing and swallowing, and there can be problems in clearing secretions with risk of aspiration. And involvement of the respiratory muscles can lead to difficulty in respiration. The muscle strength is usually normal at rest, but can be increased on exercise, and it's usually highest in the morning. This is the Myesthenia Gravis Foundation of America classification based on the severity of the disease. Association with other autoimmune disorders is seen. Most important is a thyroid disease and can also be associated with rheumatoid arthritis. Myocardial involvement is rare. Myasthenic crisis and cholinergic crisis can be seen during the course of the disease. And in the perioperative period, it is precipitated by surgery and pain and the residual effect of neuromuscular blocking agents. It is diagnosed by antibody testing and electromyographic studies. In the electromyography, there is a progressive decline in the compound muscle action potential amplitude following repetitive nerve stimulation, and there is fade on tetanic stimulation, indicating the postsynaptic nature of the disease. Edrophonium test is a non-specific test wherein improvement is seen following administration of incremental doses of edrophonium. CT and MRI of the mediastinum are done to detect thymomas. These patients can be on anticholinesterases. Most importantly is the oral pyridostigmine, which in high doses can precipitate a cholinergic crisis. And corticosteroid prednisolone can cause rise in blood glucose level and suppression of the HPA axis. And non-steroidal immunomodulators like azathioprine can cause leukopenia and hepatotoxicity. And cyclosporine is nephrotoxic and can cause CNS toxicity. Plasmapheresis and intravenous immunoglobulins are reserved for patients with myasthenic crisis and for perioperative stabilization, and this causes a transient improvement. Thymectomy is done in patients with thymomas and in all patients under the age of 45 years with positive acetylcholine receptor antibodies. This can be done by median sternotomy or as a minimally invasive procedure or even as a robotic surgery. So these patients can present to us for thymectomy for unrelated surgical or obstetric procedures. The concerns include the interactions among the disease treatment, and the drugs used for anesthesia, most importantly the neuromuscular blocking agents. The goals are to avoid exacerbation of muscle weakness and preserve the respiratory function. Coordination with neurologists is important. Elective surgery is to be done during the stable phase of the disease as it minimizes the chance of postoperative myasthenic crisis. Patients are admitted at least 2 days prior to surgery for evaluation and adjustment of medications, and they need to be counseled about the need for postoperative ventilation. It's important to know the duration and severity of the disease, as bulbar symptoms can be associated with aspiration and pneumonias. Respiratory weakness can increase the need for postoperative ventilation, and previous myasthenic crisis can trigger a crisis again. With respect to drugs, anticholinesterase, whether to stop or to continue. If we stop, there can be increase in muscle weakness, but the intraoperative muscle relaxant requirements come down. If we continue, the duration of action of succinylcholine and ester local anesthetics may be prolonged. So both are followed and it's individualized based on the patient. We have to restart as soon as the oral intake is possible, or 1/30th of the dose can be given as intravenous. Corticosteroids to be continued, immunomodulators are stopped, and association with other autoimmune disorders are sought. In the examination, it's important to document the baseline muscle strength, particularly of the respiratory muscles. In the respiratory system, evaluation is done to rule out pneumonias. And in the airway examination, particularly in patients with rheumatoid arthritis, it's important to rule out neck stiffness. CBC, RFT, and electrolytes are done in patients receiving immunomodulators, and thyroid function test is done in all the patients. CT chest and echocardiography are done in patients with thymoma. Pulmonary function testing is indicated in all the patients receiving general anesthesia. It's done in order to assess optimization, to help establish a baseline for extubation, and plan for level of postoperative care. FEC is the most commonly performed test, and an FEC of less than 2.9 liters predicts a risk for postoperative myasthenic crisis. Flow volume loops are done in patients with thymoma to assess the extent of impairment, to know whether it's fixed or dynamic airway obstruction, and should be done in both supine and upright positions. Various risk factors that can precipitate postoperative myasthenic crisis. These are patient-related, disease-related, and surgery-related. Initially, they were formulated only for median sternotomies, but subsequently they have been extended to other procedures as well. It's important to optimize the patients as it decreases the risk of surgery and improves the outcome. H2 blockers or proton pump inhibitors, chest physiotherapy, and pulmonary toilet is indicated to reduce the risk of aspiration. Breathing exercises and incentive spirometry is done, and plasmapheresis and intravenous immunoglobulin is considered when required. Should be taken up as the first case in the morning. Local or regional anesthesia is preferred. Apart from standard ASA monitors, neuromuscular monitoring, a quantitative train of 4 monitoring with a nerve stimulator is done, and a baseline train of 4 ratio of less than 0.9 implies more sensitivity to the neuromuscular blocking agents. And in patients undergoing median sternotomy, invasive blood pressure monitoring is indicated. Glycopyrrolate is given to reduce the secretions. In most of the patients, reassurance is enough for anxiolysis. If required, smallest effective dose of midazolam with monitoring for bulbar and respiratory weakness should be done, and perioperative steroid coverage is given in patients receiving corticosteroids. In regional anesthesia, there can be a prolongation of the duration of ester local anesthetics, so reduced doses of amide local anesthetics are considered. A mid-thoracic or higher level in uraxial blocks can cause paralysis of the muscles of respiration, and this can be detrimental in patients with bulbar or respiratory disease. With brachial plexus block, block of the phrenic nerve can result in diaphragmatic paralysis, particularly with interscalene approach. So use of ultrasound and low volume techniques helps to minimize this complication. Coming on to general anesthesia, a balanced general anesthesia technique, intravenous or inhalational, without the use of neuromuscular blocking agents is recommended. Due to marked sensitivity to non-depolarizing agents, the residual paralysis carries the risk of precipitating a myasthenic crisis, while excessive reversal with anticholinesterases can lead to cholinergic crisis. So propofol is the most commonly used intravenous induction agent. It can cause marked respiratory depression. Inhalation induction also can be considered. Volatile anesthetic agents are used to deepen the plane of anesthesia following intravenous induction. Sevoflurane is the preferred agent. Myasthenic patients are more sensitive to the neuromuscular depressant effects of volatile anesthetic agents. And those with a baseline TOF ratio of less than 0.9 have shown increased sensitivity to sevoflurane. For intubation, It's advised to avoid neuromuscular blocking agents as far as possible. Even patients with pure ocular form or those in remission can also be sensitive to neuromuscular blocking agents. Intubation can be readily achieved without muscle relaxation due to the intrinsic muscle weakness and the relaxant effect of volatile anesthetic agents used. Intravenous lignocaine, esmolol or fentanyl are used to attenuate intubation response. Caution with lignocaine as it can potentiate the neuromuscular blocking agents. Alternately, TIVA with remifentanil and propofol also produces good intubating conditions. In patients undergoing emergency surgeries or in those who cannot tolerate the cardiodepressant effects of volatile anesthetics or TIVA, muscle relaxants are required for intubation. They're resistant to the neuromuscular blocking effects of succinylcholine. The ED95 is 2.6 times the normal, but good intubating conditions are achieved at doses of 1.5 to 2 mg per kg, and there can be a prolongation in the duration of action. Alternately, incremental doses of 1/10 the intubating dose of rocuronium with train of monitoring can be used when Sugamadex is available. Successful airway management has been done using LMA, even for median sternotomy as well as thoracoscopic thymectomies. For maintenance, adequate relaxation for surgery can be provided by volatile anesthetic agents and intravenous agents, including thymectomy. Various combinations of TIVA or volatile anesthetic agents along with epidural anesthesia have been done. In patients receiving anticholinesterase, there can be a prolongation in the duration of action of remifentanil. It's not always possible to avoid neuromuscular blocking agents. So if required, titrate the dose 10 to 25% of the ED95 with quantitative train of 4 monitoring. Smallest dose of shortest acting agent to be used. All patients are considered sensitive unless proven otherwise. Both seropositive and seronegative are equally sensitive. And if Sugamadex is available, rocuronium is the choice. Alternately, vecuronium can be considered. If not, cisatracurium or atracurium can be used. For short surgical procedures, spontaneous ventilation with pressure support can be considered. But for longer procedures, IPPV is considered in order to promote a well-rested patient and optimal neuromuscular function. Multimodal analgesia with short-acting opioids when TIVA is not used, combined with epidural anesthesia, regional nerve block should be done, and normothermia and adequate fluid balance should be maintained. Most patients can be safely extubated at the end of the surgery. Adequate return of spontaneous ventilation, airway reflexes, and muscle strength to be confirmed, particularly the respiratory muscle strength. A quantitative train of 4 ratio of 0.9 is minimum. However, a ratio of more than 0.95 should be strongly considered to minimize the postoperative respiratory complications. To reverse or not to reverse? Before the advent of Sugamadex, concerns about cholinergic crisis with anticholinesterases was a constraint to reversal. But now, most patients can be safely reversed with Sugamadex when rocuronium is used. Also, vecuronium can be reversed. Otherwise, titrated doses of neostigmine with neuromuscular monitoring. The goal being optimal strength without cholinergic crisis. There are reports of failure of reversal with Sugamadex with subsequent reversal with neostigmine. The safety of Sugamadex as well as the efficacy has been shown in many studies in patients with Myesthenia gravis undergoing types of surgical procedures. Weakness after surgery could be due to myasthenic crisis, residual effects of neuromuscular blocking agents, or non-anesthetic drugs, or cholinergic crisis. Myasthenic crisis is defined as severe respiratory or bulbar muscle weakness that requires intubation or delays extubation. So, delay extubation or re-intubate the patient. You can consider non-invasive ventilation as well. Seek a neurological opinion. Start high-dose steroids, intravenous immunoglobulin, and plasmapheresis. Cholinergic crisis, though rare, can be precipitated by anticholinesterases, and it resembles organophosphorus poisoning. Nicotinic overstimulation can lead to muscle weakness, and there can be muscarinic symptoms as well. So, hydrophonium test helps to differentiate this from myasthenic crisis. The muscarinic symptoms are treated with either atropine or glycopyrrolate in incremental doses. Further doses of anticholinesterases to be avoided, and continuation of mechanical ventilation till spontaneous recovery should be done. These are the various drugs that can exacerbate myasthenia gravis, the aminoglycoside antibiotics, beta blockers, the local anesthetics, and many more. Postoperative care is individualized. Patients are carefully observed in the PACU, and if there are any signs of bulbar or respiratory muscle weakness, they'll require respiratory support. Early postoperative strength may be normal, but can deteriorate after few hours. Oral anticholinesterase to be restarted, and optimal pain relief is important as it can trigger myasthenic crisis. So a multimodal analgesia, and better to avoid opioids or short-acting opioids preferred, and NSAIDs can reduce the opioid requirements. And in pregnancy, if well controlled, it remains stable. Exacerbations are seen in first and third trimester. There can be increased instrumental deliveries, so labor analgesia should be planned accordingly. Neuraxial blocks are preferred for cesarean section, and general anesthesia is reserved in patients with bulbar or respiratory muscle weakness. And beta blockers and calcium channel blockers to be avoided in patients with preeclampsia. Alternately, methyl dopar hydralazine is preferred, and magnesium sulfate is used only if absolutely necessary. Instead, levetiracetam or valproate can be preferred for seizures, and phenytoin is reserved for refractory seizures. And transcendental neonatal myasthenia can happen, so access to neonatal critical care is must. To sum up, elective surgery to be done during the stable phase of disease with optimization, avoid exacerbation of muscle weakness and preserve respiratory function, use regional anesthesia as far as possible, avoid neuromuscular blocking agents. If required, rocuronium with Sugammadex is preferred. Individualized postoperative care based on the severity of the disease and surgery to be considered. Availability of ultra-short-acting opioids, precise TCI pumps, modern volatile anesthetic agents, rocuronium and Sugammadex have made management safer. So I think we all know about Amitabh Bachchan. The other person on the left is Mr. Vijay Tendulkar. He's a Marathi playwright who succumbed to myasthenia gravis in 2008. Thank you.